So here you are watching coblation adenoidectomy in a 7-year-old kid with history of mouth breathing, difficulty in sleeping, and you can see she has almost got a grade 4 adenoid. We are using coblation at the setting of 9 for ablation and 4 for coagulation. You can use 3 or 4 anything for coagulation. Now I am starting from the upper pole. The wand is through the oral cavity. The endoscope is through the nasal cavity. Routine 4 mm 0 degree endoscope. And you can see that's the superior boundary of the adenoid, which is the periosteum below the sphenoid bone. So it's important to reach the boundaries because otherwise you can get a recurrence. And if you go till the boundaries, then the recurrence is absolutely minimal. Chances of recurrence are absolutely minimal. So that's the superior boundary. Now I am removing the tissues layer by layer, and you are not supposed to open up this periosteum. You are only supposed to reach the periosteum. And then debulking of the adenoid layer by layer. Let me try to focus the endoscope a little better. I think this is the best. And then as you can see, we can remove almost every bit of lymphoid tissue going layer by layer, and that's the third dimension, the depth of the adenoid. Now we'll reach the posterior boundary very soon, which is the buccopharyngeal fascia. And that's the buccopharyngeal fascia. Can you see that fascia? That's the fascia. Again, you're not supposed to open up the fascia. We will only define the fascia. That's the fascia. You can very clearly see the fascia. And layer by layer, we are removing all the tissues on top of it. So that's the posterior boundary. And this is the inferior boundary, the torus tuberous, sorry, the Passavant's ridge. You can see the adenoids are ending over here, and you can see the horizontal contractions. Now I am going laterally. So laterally, this is the eustachian tube. This is the torus tuberous. Can you pour some saline? All right. So some saline can be poured to clear up your scope. Now these are the tubal tonsils. So I am removing the tubal tonsils submucosally only till the level of the submucosa, not entering into the muscle. This is the anterior boundary laterally. And as you go posteriorly, you will get into the fossa of Rosenmuller. So the lateral boundary posteriorly is the fossa of Rosenmuller. That's the fossa of Rosenmuller. And very, very gently, we'll remove all the lymphoid tissues from the fossa of Rosenmuller so that they never come back. When you go laterally, you do not direct your wand laterally. You can direct the wand medially so that you see what you are doing. Because you can have an aberrant vessel coming from the lateral side, so you should not be accidentally damaging that vessel, and therefore you direct the wand medially. If you have to direct the wand laterally, then you can coagulate, do not ablate. These are the small tips by which you can avoid a complication. Now the dissection on the left side is almost over. Just a little more here. That's it. Right? And I'll now go on to the right side and do the same work. Thank you for watching the boundaries of the adenoid on the left hand side.